Dr. Ashish. He'll be presenting on a hybrid 26 gauge needle drainage technique in scleral buckling, and the discussant will be Dr. C.V. Gopal Raju, sir.
Very good afternoon to all. So I'll be talking about hybrid 26 gauge needle drainage technique in scleral buckling, a mini scleral cut down. So there are various techniques to drain the fluid from drain subretinal fluid in cases of scleral buckling. And the initial technique was described by Shippens, which was actually a two-step scleral cut down, where he used a scleral blade and then diathermizing the choroid and then using a needle to drain the fluid. Because of the large sclerotomy, there is a risk of retinal and vitreous incarceration, bleeding from the choroid, and sudden hypotony. To counter this, there are various other needle drainage techniques which have been described, like needle drainage technique, modified needle drainage technique, and a guarded needle drainage technique. Now, the technique described by Charles et al., it involves the use of indirect ophthalmoscopy and a use of a 25G needle, which passes obliquely through the sclera into the subretinal space. The problem is that it is a steep learning curve, and also oblique passes through the choroid increases the chances of choroidal hemorrhage. Contrary to this, the technique described by Azad et al. Uses a 26 gauge needle without a plunger, does not require an indirect ophthalmoscope, and and we have to go perpendicular into the subretinal space. But the problem which I felt while I was in my residency doing this modified needle drainage technique was that as soon as the needle enters into the subretinal space and crosses the sclera as well as the choroid, there is a sudden loss of resistance. And as a result, the needle just gives away, and there's a high chance that the needle might go and hit the retinal surface, especially in cases of shallow retinal detachments. So there's a jerk which is felt as soon as the needle pierces the choroid as well as the sclera. So basically, to avoid this jerk, we have described a technique where we perform a mini scleral cut down using a 26 gauge needle, and we have called it as a hybrid needle drainage technique, which is a hybrid of a scleral cut down technique and a modified needle drainage technique. So in this technique, basically, what we do is we create a mini scleral cut down using the tip of a 26 gauge needle. So here, this is done by doing linear movements and scraping of the scleral surface. And this is done till the choroid starts to appear. So it is at this point that very gently you poke inside the subretinal space using the tip of the needle. And it leads to a passive aggression of fluid. Following this, a cotton bud applicator is used to basically drain out rest of the fluid. So we've already published this technique as a pilot study in Indian Journal of Ophthalmology, and it was a retrospective study where we evaluated the efficacy and safety of hybrid 26 gauge needle drainage technique in scleral buckling. Intraoperative surgical details and postoperative details were noted down, and the adequacy of drainage was assessed by indirect ophthalmoscopy. And it was graded from grade 1 to grade 4, where grade 1 was defined as a complete drainage of subretinal fluid, whereas grade 4 was defined as dry tab. So a total of 10 patients were done, and a complete drainage of SRF was achieved in 5 patients, and a partial but adequate drainage was achieved in rest of the 5 patients. In none of the patients, inadequate or dry trap was encountered. No intraoperative complications were encountered. And in most of the cases, we were able to drain in a single attempt. Only in 2 cases, 2 attempts were required. The retina was attached in 8 out of 10 eyes at 1 week and 1 month of follow-up. So till date, we performed roughly around 70 to 80 cases with a similar technique. And what we have found is that it has various advantages, like it is more controlled, and this can even be performed in cases of shallow retinal detachments. As the point of entry through the choroid is so small, diathermy of the choroid before entering into the subretinal space is not required. This small opening in the choroid also avoids the risk of vitreous or retinal incarceration. And as the needle is entering into the subretinal space in a perpendicular fashion, so the chances of choroidal hemorrhage or subretinal hemorrhage are drastically reduced. Thank you.
Yeah, that was a good innovation, but only you are using the needle instead of the blade of the earlier technique, and then the size also it is less when compared with the that
Yes,
is
sir. The problem with needle technique is, sir, it gives a sudden jerk most of the times. So it is always better to scrape off the scleral surface first. It will reduce the resistance, and then one can easily poke in.
but earlier we were using the blade and then cauterizing.
Yes,
So
sir.
this is only you are avoiding cautery, and then the opening also is less. These are the two improvements.
Yes, sir. But
Uh,
with the blade, there is no we are not able to actually scrape off the scleral surface. We can actually make a cut in the sclera. In this, even if it is a thin sclera like high myopics, you can actually control how much amount of sclera you want to scrape off. And then as soon as the choroid is visible, you just gently poke inside.
okay, good.